Good afternoon, everyone. The title of my talk today is SARS-CoV-2 and COVID-19 Explained. SARS-CoV-2 is the name of the virus. The name of the disease is COVID-19, which stands for coronavirus disease, and the number 19 obviously stands for 2019, which is when we first started seeing this infection emerge in Wuhan, China. My name is Bindu Mayi. I am a professor of microbiology at the Dr. Kiran Patel College of Osteopathic Medicine at Nova Southeastern University. My other creds, I love to write, so I've written a couple of books, one on prevention of MRSA and the other one on solutions to mass shootings. And I have a blog that's geared specifically towards prevention of infections. Okay, so the learning objectives, there are three. In the brief time that we have, I will do my best to impart to you some knowledge about the pathogenesis, transmission, and prevention of SARS-CoV-2. We'll compare and contrast SARS-CoV-2 with the last pandemic respiratory virus, which is H1N1. And then very briefly, I'll talk about the significance and impact of zoonotic spillover. That said, let's talk about SARS-CoV-2. Before we talk about the virus, I want to mention that coronaviruses have been around for a while, and there are now 7 members which are endemic globally. That means we see infections every single year all over the world, and they cause about 10 to 30% of upper respiratory tract infections. What that means is just a cold. So this is the second most common cause of the common cold, the first one being rhinovirus. Okay, so just a cold, no big deal. The first notorious member in this family was the SARS coronavirus, which emerged onto the scene in 2002, 2003. And research subsequently showed that the natural reservoir for these viruses, the SARS coronavirus, was the Chinese horseshoe bat. And this virus causes atypical pneumonia, which is what the current virus also causes. After everything was said and done, we saw 8,098 infections across 37 countries with this virus. And that resulted in about 774 deaths, giving us a mortality of 9%. That means 9 out of 100 people who get this will die from it. Now, when we factored in age, so people 65 and older had a higher mortality. So the mortality went up from 9% to greater than 50% in the elderly population. Okay, so how did it get to us from bats? There was an intermediate host, and that intermediate host was the masked palm civet. So in live animal markets, these masked palm civets picked up the infection from wild bats that were also in the market. People who purchased and slaughtered these animals were subsequently infected with the virus that they picked up from the masked palm civet. The virus then underwent a mutation so that now it could show sustained human-to-human transmission as well. When the virus was subsequently genomed, we saw that it shared about 99.8% of its genetic sequence with a coronavirus that was isolated from a masked civet. This controlled SARS. When it burst onto the scene in about 8 months or so, it petered out, and we haven't seen it since. What helped us tremendously was the fact that only symptomatic individuals were contagious. So what we were able to do at the time was we knew who were infected because they were showing up with symptoms. We could isolate them, put into place very strict infection control practices. And then we did vigorous contact tracing. And when we did the contact tracing, we monitored the contacts for symptoms as well, followed by isolating if necessary. So this is public health 101. And I cannot reiterate enough the importance of these measures, which is what really helped us keep the SARS numbers down to what we did. The next notorious coronavirus member that burst onto the scene was in 2012, and that was the Middle East Respiratory Syndrome coronavirus. So that's the MERS coronavirus. The natural reservoir in this case was also bats. This also caused atypical pneumonia, which is what SARS did. And the mortality rate for this was a little bit higher. It shows approximately 36% mortality across all age groups, which makes it one of the most lethal human viruses that we know of. And again, here too, when we factor in age, so in the elderly population, this showed greater than 50% mortality. The intermediate host in this case was the dromedary camel of Middle Eastern origin. So as of November 2019, which is when we have the most up-to-date information, there have been 2,494 infections and 858 deaths, the vast majority of them being in Saudi Arabia. So this virus hasn't really gone away. It's kind of percolating in the background with cases every once in a while. And now we have the new coronavirus. So when the new coronavirus burst onto the scene and researchers sequenced the virus and we compared the genetic sequence with these other notorious coronaviruses and did a tracing of ancestry, we realized that this is also a beta coronavirus gene, it is a beta coronavirus similar to SARS coronavirus, which belongs in this section, and similar to MERS coronavirus, which belongs in this section. But the new virus has greater similarity to the SARS coronavirus and falls closer to the SARS coronavirus. Hence, the name suggested by scientists was a SARS coronavirus 2. Okay, that's why that's the name of the new virus. As far as what is the intermediate species that brought this virus to us, it shows, and where did it originally come from? Did it also come from bats? We seem to think yes. And the reason for that is the virus shows greater than 96% identity at the genome level to a known bat coronavirus that was isolated from a bat cave in Wuhan back in 2015. There's also about 90.3% genetic similarity between coronaviruses from pangolins, which is a mammal that's actually sold illegally for its meat, as well as scales that have medicinal properties in ancient Chinese medicine. So there's 90.3% genetic similarity between a coronavirus isolated from this animal as well as infected humans. Now, this is far less than the 99.8% genetic similarity that we saw between SARS coronavirus, the first one, and the masked palm civet. So the verdict is still out whether pangolin is the intermediate species, so the scientists are still looking for what might be an intermediate species, okay? So as far as range of symptoms, so what does this virus cause? There may be no symptoms, which we know now, right? And yet people can be contagious, to mild symptoms, to severe symptoms, so severe that people need to be hospitalized. In fact, these hospitalizations in severe cases also end up resulting in death. So we see the entire range of symptoms. Some reports describe asymptomatic or subclinical infection, right? And in these cases, we've still been able to detect not just RNA, but also live virus. What that implies, again, is the ability to infect someone else. And either the genomic material or the live virus was isolated from throat swab specimens of contacts of people who were confirmed to have the virus. And initially, these people came to our attention because let's look at what the symptoms are that get you the medical attention you need. The most common symptoms seem to be fever, cough, and shortness of breath. Although there have been cases where there is no fever, there is no cough, or it progresses to an extent and then all of a sudden there is shortness of breath. Okay. In Germany, in addition, about 66% of the cases of confirmed disease, confirmed COVID-19, also seem to have a loss of sense of smell. And in South Korea as well, they saw a similar finding, which is 30% of people with mild symptoms who tested positive for this virus also reported a sense of loss of sense of smell as their main symptom. Now, we still need to figure out and do some scientific research to figure out if we can use this as a predictor of COVID-19. And in this country, when the CDC did an analysis of patients who were hospitalized, there were about 2,499 patients in this study conducted by the CDC. we saw that over half of the ICU admissions and deaths happened in individuals 65 and older. No big surprise there, right? It goes, it aligns with what we've seen elsewhere as well. But in addition, we saw that younger adults also experience disease severity. So for instance, age group 20 to 44 years of age contributed to 20% of hospitalizations and 12% of admissions to the ICU. 45 to 64 made up 35% of hospitalizations and 36% of admissions to the ICU. Among 44 cases with known outcome, age group 85 and older contributed to 34% of deaths, 65 to 84, 46%, and then you go down. As the age decreases, you have lower mortality. But this was very surprising for us. As high as 20% of mortality was seen in the age group 20 to 64. And in age group 19 and under, in this particular study, there were no deaths. Since then, we have seen 3 deaths in children due to COVID-19, but we're still trying to figure out if that was indeed the cause of death. So that research is still going on. So as to why young people are succumbing, there are a few theories about this, one of which is that SARS-CoV-2 binds to this receptor called ACE2, which is on the surface of the cell that it's going to infect, right? And that interaction is essential for the virus to now enter the cell and start replicating and create more copies of itself. One theory is that there may be genetic variations in this ACE2, the receptor that the virus binds to, such that there is differing susceptibilities no matter what your age might be. Okay, so if there's a variation in this ACE2, then it might alter the ability of the virus to enter the cells. That's one theory. Another theory is that the surfactant, which allows our lungs to function, may become depleted in some patients that are infected with the virus. We are still trying to figure out why that happens. But this may be why some individuals, some patients continue to struggle, even when they are put on a ventilator that should be helping them getting enough oxygen into their system. The third theory is that when you have a robust immune system, for some reason in some individuals, there is an uncontrolled immune response, which we also call a massive cytokine storm. So cytokines are chemicals that will signal other immune mediators to rush to the scene of crime so they can clean up the infected cells. When there is an overabundant response and an aggressive response, this inadvertently ends up creating more damage, which is why immune suppressants are benefiting some people. And the last theory is that younger, healthier people, thinking that they're not vulnerable to this infection, may be less diligent about social distancing and inadvertently get exposed to much larger viral loads from the environment. So that brings me to social distancing, which is a crucial measure of our response against this virus. So what exactly is that? Social distancing is deliberately increasing physical space between people, so you avoid spreading the infection. And the main reason why this works is viruses are strict parasites. If you stop a virus, this particular virus, from finding another human, that's the end of the road for the virus. It needs more people to keep on replicating, to keep on multiplying. So if you prevent it from infecting more people, that's it, the pandemic peters out. So what does social distancing mean? When we deliberately increase physical space, staying at least 6 feet away from others, this lessens our chances of catching the infection. Other examples of social distancing include working from home instead of office, which is what I'm currently doing, closing schools and switching to online classes, right? Visiting family, especially vulnerable family members, by using technology instead of visiting in person, and canceling or rescheduling conferences as well as large meetings. All of these things are happening currently. So the people that we try desperately to protect are the ones that are at highest risk of severe illness and consequently death. So these include our elderly population, individuals 65 and older, those with chronic lung disease or moderate to severe asthma, people with serious heart conditions, people who are immunocompromised due to any number of reasons. Those with severe obesity, diabetes, chronic kidney disease, liver disease, all of these individuals are at higher risk for severe illness. So how does the virus itself get transmitted? We know that transmission takes place person to person. So you have to be, the CDC thinks that you have to be in close contact within 6 feet of one another. How does the transmission take place? You're inhaling infectious droplets. Where do these droplets come from? The infected person either coughs it out or sneezes it out, so that the susceptible person now inhales these droplets and can come down with this infection. In addition to directly inhaling these particles may also fall onto surfaces, which can then act as a source of transmission. And I'll speak briefly about surfaces in just a second. So we now know there is both symptomatic as well as asymptomatic spread, right? So a person who is symptomatic spreads the virus, but a person who has no symptoms and is infected with the virus can also spread the virus. In addition, surfaces act as a source of transmission of the virus. We know from research done at the NIH that the virus can remain viable, that means alive, and infectious in aerosols for up to 3 hours, and on surfaces for up to days. We've been able to detect viable virus on cardboard for up to a day, and on plastic and stainless steel for up to 3 days. Okay, so how do we protect ourselves? The recommendations from the CDC, if you have symptoms, if you're coughing and sneezing, etc., then you trap those particles in a tissue and then dispose of that tissue. Once you dispose of that tissue in a lined trash can with a lid that you preferably are not touching with your hands, it's foot pedal operated, then you wash your hands adequately, either with soap and water if it's visibly soiled, or using an alcohol-based hand sanitizer. Stay home if you're sick. If you have to be out in the community to go see your medical care provider or the pharmacist, wear a face mask. And now, of course, the CDC recommends that anyone who is going to be in a crowd of people, or if they're stepping outside the house and going to the grocery store or the pharmacy, to wear a mask, whether it's a store-bought or a homemade mask, right? Disinfect frequently touched surfaces. This is at home. If you have someone else at home who is sick and self-isolating, clean all the areas that come in contact with multiple people, including the person who is now sick. Use disinfectants. The CDC has a list of EPA-registered disinfectants that seem to be effective. And then, of course, engage in social isolation. All of these are recommendations from the CDC. Right, as far as who gets tested for SARS-CoV-2, because we have limited tests, the CDC has left it to the clinician's judgment to determine who has signs and symptoms that seem to be indicative of this infection, and whether that person needs to get tested. So this, as you know, is a zoonotic spillover. This is not the first zoonotic pathogen that we've had. Other examples include the SARS coronavirus from 2002, 2003, MERS from 2012, this current one, of course, which is ongoing, the 2009 pandemic strain, which came to us as a reassortment, mixing and matching of viruses from swine, pigs, birds, and humans. Ebola, which there is a small outbreak going on still in the Democratic Republic of the Congo. In addition, there are other pathogens such as Salmonella, Leptospira, West Nile. We see it every single year just in this country. All of these are examples of zoonotic spillover. I'm going to do a brief comparison and contrast with one of these zoonotic spillover pathogens, which was the 2009 pandemic H1N1, and then we'll end with how exactly does the spillover happen for these zoonotic infections. So what did we see with our last respiratory pandemic? Few young people had any existing immunity to this virus, as we saw based on the antibody response. Almost 1/3 of the people over the age of 60 had antibodies against this pandemic strain, which spread all through the world, right? So we think that's likely from exposure to an older H1N1 virus that was similar in genetic structure. that these individuals were exposed to earlier in their lives. The CDC estimated about 151,000 deaths to 575,000 deaths from this pandemic strain. 80% of deaths were in people under the age of 65. This is very different from what we see typically during our seasonal flu epidemics, when we see the majority of deaths in people 65 and older, right? So this is different from what we are seeing currently. As far as how to say spillover happen, as you can see, there are many layers between the pathogen and the human so all of these layers have to align properly, right, for the spillover to take place. So even though the potential for spillover exists, it is not as common as we think it is, right? So, but what's important for us to know is what are these barriers, such as pathogen prevalence, reservoir host distribution. That means where is it found in the animal kingdom and how prevalent is it? How dense may that host get from year to year? So all of these things have to line up, and it's important for us to study these barriers and quantify them so we can better do a risk assessment and ultimately do some public health planning. So I think that brings me to the end of my talk. I want to thank the Nova Southeastern University Alumni Association, the Division of Advancement and Community Relations, for putting together this talk. Thank you very much. I'm happy to take questions.
Hi, doctor. We have a question from someone, and she says, with current local and national regulations, in your opinion, how long will it take for our country to eliminate social distancing as a preventative measure? When can we expect to go back to school or work?
That's a very good question, and that's a question that we all want an answer to. And unfortunately, there is no easy answer. But what we can do to help us get to that is continue watching the trend. So New York, for instance, right? New York was the epicenter here in our country. And now you see that it has a downward slope for a number of new cases, right? So we need to see that in cases all across the country. In addition to that, what's going to be extremely important is for us to administer widespread testing. We really need to know how many people are actually infected. So when we do that, there are two kinds of testings. One that looks at it's a molecular assay, which is an RT-PCR, where you're looking to see if the person is positive for the virus, right? And then there is another test, which is an antibody test that tells you what level of immunity you have once you've been infected. So both of these tests need to be rolled out to many more people than it currently is. Once we know who's immune, those individuals will be able to be out in the community and contribute to try and restore as normal of a life as possible. So unfortunately, there is no easy answer, but we can get to that by watching what's happening, continuing to do social distancing, because remember, viruses are strict parasites. If we stop an infected person from coming in contact with another person who hasn't seen the infection, then that's the end of the road for that virus. And that's not so easy to do because not everyone who's infected is symptomatic. So those tests are going to be absolutely important also. Does that answer your question?
Thank you. Another question we have is, I tend to run around my neighborhood as often as I can to get sunlight. Is that a good idea considering infectious air droplets? How long can these droplets stay airborne?
So the study, that's a great question. The study was done in a controlled lab environment, right? In an enclosed space. So that 3-hour margin becomes very important. So in that study, we showed that aerosols stayed around, the virus stayed in aerosols for up to 3 hours. That becomes an important consideration in a high-risk environment, such as a nursing home where there's an outbreak, or a healthcare facility, such as a hospital, the emergency department, an entire floor of COVID patients, etc. So when you're out running about, where that air exchange is tremendously greater, right? So your risk is far less if you have any concern because you may have a condition, either a pulmonary condition or an immunodeficient condition of any sort, then wearing a mask would certainly create a barrier. But aerosol risk is typically not a risk in a non-crowded setting outside. And we know that based on other pathogens such as measles, etc.
Thank you. Another question is, should we use a filter in our fabric masks? And also, should we wash each mask after use?
What was the first part? Sorry, you got cut out. What about the filter?
The question was, should we use a filter in our fabric masks? And if so, should we wash the mask after each use?
What sort of a filter are you talking about? The CDC has instructions on homemade masks, and they've asked to use 2 layers of, when you sew the mask, to use 2 pieces of fabric to create a mask. Anything that you add to that is going to only enhance the barrier, right? So from the CDC's point of view, their main concern is to stop infected asymptomatic people from being the source of transmission. So let's say if I'm infected, asymptomatic, but I'm still contagious, then wearing that mask is going to stop those aerosols and droplets from being out in the air, whether I'm at a grocery store or a pharmacy or at home, right? But at home, if no one else is going outside, then you know that you haven't been exposed to someone else who has, who's in a similar situation, infected and asymptomatic and therefore contagious. So anything that you can add to enhance the barrier is only going to help you, in my opinion.
Thank you. Another question that we have is, could you please give your thoughts on some of the early indications that indicate the COVID-19 virus may be causing thrombotic events in some affected individuals?
I'm not sure I have read anything about that, unfortunately. So I'm not sure how to address that. Sorry.
So another question we have from our viewers, currently, what is the progress on creating a vaccine for this particular strand of disease? Go ahead.
So what's exciting is, and this platform technology was put into place during the last SARS outbreak that we saw in 2002, 2003. So typically what would take us decades to get to a viable vaccine candidate, it now took us just 3 months. Imagine how exciting, right? So in 3 months, NIH has had a viable vaccine candidate that has been put into phase 1 clinical trials. So there are a couple more phases to go. So when everything's said and done, it'll probably take us at least another year, maybe a year and a half before we have a vaccine candidate. That's assuming that it is safe and efficacious. So we know that based on clinical trials. So our phase 1 trial results should be out either by the middle of this month or by the end of this month. And after that, we scale it up to more patients, to more participants in phase 2 and then phase 3. So if everything goes according to plan and it's safe and effective and has no adverse events, then we should be having a vaccine that's FDA approved sometime towards the latter part of next year.
Is the 6 feet rule enough for conversations or speech transmissions of infectious droplets, let alone sneezes and coughs, in your opinion?
I love that question. So there was a research study done at MIT back in 2012 that showed the trajectory of a cough and sneeze particle. And they showed that for an open mouth cough or a sneeze, these aerosols and droplets can go much farther than what we originally anticipated. So the larger droplets fall onto the ground, but the aerosols can go as far as 20 to 26 feet. They can stay around in air, get batted around by air currents, get picked up by the air vent, etc. So how do we avoid those things from carrying this current virus over long distances is the use of that mask, right? Especially important when you are going to be in a crowd of people. So at this time, with our lockdown measures and social distancing, that crowd of people would be in a grocery store or at the pharmacy, which is where most people seem to be going. So if you trap those particles, so let's say if you don't have a mask and you have a cough or a sneeze coming on, then what you want to do absolutely is to trap the cough and sneeze particles, so you're not letting these particles travel through the air. That's a great question.
Thank you. Do you have suggestions on vitamin supplements like zinc, tonic water, and elderberry, or things that are beneficial for immunity?
That's also another great question. So what we want to do and what's going to help us against not just this current virus, but against all infections really is to have a good immune system. And it's easy to say that, but what exactly does that mean when you have healthcare workers who are overworked, perhaps, especially in this situation, or when someone's stressed out because there's an exam coming up and they're studying really, really hard and having sleepless nights, etc. So lots of things go towards building your immune system. Eating well, what does that mean? It means not eating processed foods, eating naturally as much as you can, hydrating enough. Elderberry, definitely, it's something we certainly use in our household, in my opinion, and I've seen some indication that it also seems to, I've seen some papers that talk about use of elderberry in fighting respiratory infections. So we certainly take that. If you feel run down, you either take a lozenge or you take the tonic. Exercise, if you haven't ever exercised before, you want to start it by consulting your healthcare provider. De-stressing, how do you de-stress? Mindfulness, meditation, laughing, reading a good book, socializing, which is challenging in this day and age, unless you have your family around you and you all get along, right? But use technology to socialize with your friends and have conversations and support each other. But definitely boosting your immune system can be done with all of those things.
A question from Charles. Do ACE inhibitors make the infection worse or lessen it?
It's not such an easy question for me to answer, and I had consulted a pharmacologist early on as soon as we realized that ACE2 is the inhibitor. ACE2 is the receptor for this virus. And I'm terribly sorry, but I have completely forgotten our conversation because all of it was Greek to me at the time. But I remember him saying that it's not such an easy answer. Sorry, it's a non-answer to your question.
Thank you. Another question, and we only have time for maybe 2 more. Are you allowed to be in pools during this virus? Is the water contaminated?
The water, no. Are you talking about community pools, or if you live in a condominium complex or an apartment building, the community pool there? Is that what you're talking about?
Yes, the community pool or bodies of water.
So as long as the facilities that you use to get to the pool are disinfected, because they are frequently touched surface, there must be frequently touched surfaces for you to get to the pool. As long as those are disinfected, and then once you get into the pool, of course, the pool water is chlorinated, that shouldn't be an issue.
And lastly, our last question, could you please tell us if we should worry about the transmission of the virus to our pets, dogs, cats, etc.?
Right. So there was a study that recently came out of China, and this was done under very artificial conditions where they put a high load of the virus in the animals. And they saw that they were able to, when they put it into the nose of the cats, but a very high load of the virus, they were able to infect cats. And then these cats were around 3 other cats, and only one of the other cats picked up the infection. But none of them got sick from it. So at this time, we just don't know. But in that comparison, in that study, they showed that it's not so easy to infect dogs, even under those artificially controlled conditions, but they were able to infect cats. But none of the animals were sick in that scenario. So the verdict is still out on that one.
Thank you, Doctor. That is actually all the time that we have, but could you please share your contact information for those who still want to ask you questions? We have a ton of them.
Yes, so my email is my last name, which is M like Mary, A like Apple, Y like yes, I like India, at nova.edu. That's N like Nancy, O like Orange, B like Victor, A like Apple, .edu, Mayi at nova.edu.
Thank you. Is there anything else you'd like to add to our viewers before this meeting ends?
I think I tried to go through a lot as quickly as I possibly could, but I think this is going to be behind us. So everything that we're doing, continue doing that, continue doing the social distancing until we hear otherwise. Shore up your immune system. I know I've gotten a lot of emails telling me about how stressed some of our students are. So every day do something to actively de-stress, so you're not battering your immune system with stress.
Thank you so much. We will be ending this webinar, and we appreciate you being our expert for this week. Thank you.
You're very welcome. Bye-bye.